Good afternoon, everyone. Thanks for joining us. I do see that Dr. Dawn Mountner is here with us, and we are going to be inviting her to speak to everybody. Initially, we thought it would be a good way to kind of move into this discussion is to just have somebody, not just somebody, but a lead senior health advisor in the COVID-19 response and recovery unit, talk a little bit about the vaccine and share information with everyone, just to kind of give us a foundation then for moving into discussion about the rules. So thank you for joining us. And with that, I will turn it over to Dr. Mountner.
Hi, everybody. Thanks for having me. Dr. Dawn Mountner, family doc, she, her, ella, white woman, long brown hair. Happy to be here. I come to sessions to talk about vaccine with a couple of things in mind. One is that we have pretty good evidence that the vaccine is protecting people from severe and fatal COVID-19 and from hospitalization. Also, there are a whole bunch of questions and concerns about the vaccines, and I'm happy to help field some of those to the best of my ability. Here is my commitment to you. I will tell you what we know. I will tell you what we don't know. I will tell you what the limitations are, and where there's still mixed evidence, we're trying to sort out what's actually true. I won't say we know what this COVID vaccine does to us in 20 years. We can't know that. We only got it last year. We do know a little bit about mRNA treatments and what they can do for people in some other ways, and that they've been studied for 20 years and used for 10, so that we know that they don't do terrible things to your reproductive tract, or they don't modify your genetics. They actually wash out of your system after you get them, and that they only modify a tiny little bit of, they give instructions for how to make a protein with a tiny little chunk of genetic information, which then washes away. So there's no more vaccine left in your system. So we do know, even though we don't know what this vaccine does to you in 20 years, we do know what it doesn't do in those ways. So that is what I swear that I will do. I will depend on the science we have. I will tell you what we do know and where there are still questions, and I will tell the truth to the very best of my ability. Please be aware that the evidence is changing all the time, and so sometimes our policies have to change too, because they're based on the best evidence there is. This body of evidence is growing. When we started this pandemic, we didn't have good evidence that masks work against very much of anything. So I said, we don't have evidence, we shouldn't be doing that. And then it turned out that they do help. And so I changed my position, and now my kids wear masks, and so do I, because they really do help. And the same is true for vaccines. They really do help, even though there are certainly plenty of questions about how they came to be and how fast they came to be, and how it is that we can know that they are safe and effective. So I can share with you some of those things. Let's see, let's talk about COVID for a minute. May I share my screen?
Please.
Okay. This is always scary. We'll see what shows up. Uh-oh. Oh, what was that? Here. Okay, so you can see the curve.
Yes.
All right, well, you could see it here. Here is the curve that we're talking about. Flatten the curve. This is the epi curve. You can see, and you already know, you're on the front lines providing service to some of our most vulnerable members of society. So thank you for the work that you do, and for putting yourself at risk when you do it. that kind of work is really hard, including knowing how to assess risk, which humans are notoriously bad at doing. People are afraid to fly in airplanes, even though the driving to work every day is where we're at the greatest risk. We're really bad at assessing risk. And there's a whole lot of information out in the world. So figuring out what information to use is a really important element. Okay, so here we are. The number of cases has skyrocketed past where it was in last year's highest peak at the end of the year. You know this. You know too that this means that our hospitals are overflowing, and it's a bad place to be right now. You don't want to have to be in our hospitals right now. You have also likely heard that children are being affected more now, or at least we're picking up that they are being affected more now. So here's the curve of children's cases, and it's also shooting up, even though it may be plateauing a little bit, and that was true for the overall case count as well. You have to take this last couple weeks with a grain of salt because reporting is delayed, so we don't actually know what's happening at the very end, this grade part, but maybe this plateau is real. That would be good. Here is the alarming thing about this page. This is all from our website. You can see here that the rates of infections in kids are 3 and 4 times as high in Pacific Islander youth and in American Indian, Alaska Native youth and in Black youth as they are in white, Asian, and potentially multi-cultural individuals. So multiracial, excuse me. These are self-reported, but these rates are alarmingly different. The same is true for roughly 4 times the rates in youth who identify as Hispanic compared to those who are identifying as non-Hispanic. So those inequities are amplified. We are also seeing that that multi-generational households are showing higher rates of pediatric infections. So more infections in kids in multi-generational households. That makes vaccination in those cases even more important. Okay. Next dashboard, the variants. So as you know, Delta variant is pretty dominant right now. This yellow is Delta. This is what it's looked like over time. These were all of these other combined types. Here we had a little while with Epsilon, but mostly what we're seeing ever since we have gotten a handle on this is Delta. I'm sorry about that. That's what that yellow is. Next curve that I wanted to share with you is the proportion of individuals in Oregon, 18 and older, who are vaccinated at this point. This is 18 and older. Remember that means that there are a whole lot of kids who are not yet vaccinated because vaccine is not available for them, obviously. Here is the healthcare workforce vaccine uptake. And what you're seeing here, the take-home message is that healthcare workers are getting vaccinated at a higher rate than the general population across all age groups, with the exception of individuals greater than 70 years of age. But healthcare workers have, by and large, decided that vaccination is a good idea, and as you know, in the long-term care world, because your residents are at such higher risk, protecting them and yourselves from COVID is a really important thing to do, and vaccine can help you do that, even if you have questions and concerns about that. This is the dashboard website that I like to share because that's how we share a huge amount of data. And Oregon shares way more data than a lot of states, but there's a huge number of the questions that I get asked all the time can be answered by going to this website and looking through these different charts and graphs. This is the hospital capacity one that currently has us so frightened because the hospitals are at and beyond their limits. They're taking care of more people per provider than they usually do. They can do that because they have that that flexibility when they get into crisis situations, but it's nobody's idea of a good time for nurses to be caring for more individuals, for those ratios to change. And we know that's true in your facilities as well, and we only do it when we have to offer that flexibility so that existing staffing can take care of the individuals who need care. And here you have the reality that the number of individuals with COVID is much higher than it ever has been, and the number of patients this is in hospitals, this is in ICUs, and this is in ventilators. Those on ventilators now are more than we even had hospitalized for a bunch of the pandemic, and more on ventilators now than we ever had in the ICU before. People are getting really sick, including much younger people with COVID at this time. That's what Delta is doing. So, okay, I'll take down the screen and see if I can answer some questions. Some questions that were asked before include, how does the vaccine affect reproductive capacity? It doesn't affect reproductive capacity. It doesn't go anywhere near those parts of a body that impact reproduction, including, as I was starting to explain, it doesn't modify genetics in any way that stays put in a body and can impact your DNA, for example, of your body, or the DNA of any offspring you may have. It doesn't impact those things. It doesn't have microchips. We're not that good. Probably there are some who wish they were that good, but we're not that good to track via microchip. I would be happiest to be addressing questions that people have in the chat, making it most relevant. And so if there are some questions, I would like to direct my attention to that. Do we have any questions?
So we've got some similar questions, Dr. Vander. One is around, types of vaccines. Can you speak to whether or not one vaccine is better against Delta than others?
Sure. We're seeing really quite good protection from all three. It is true that Pfizer and Moderna might have a slight edge over the J&J, but the J&J is also still really good. Pretty good protection. And of course, while you still may have a breakthrough infection, mild or moderate, mostly they're quite mild relative to the severity of disease that we're seeing in a lot of other people. So as you know, the primary protection that the vaccine offers is keeping you from disease that's severe enough to require hospitalization or potentially be fatal. And all three of the US authorized vaccines, now Pfizer is approved, all three of those are pretty good.
Okay. Also some questions around side effects. How can we know for sure if there's no data of long-term effects? And are there any known side effects yet for the vaccinations given so far? Sure.
Yeah, we do know some things about that. I mean, we certainly know about vaccines. In general, there's always the possibility of pain at the site, some redness, some swelling, all of that. There's also, with this, because it's such an activation of the immune system, there's also the possibility of fever, of what I call, when I'm talking to my patients, I say feeling yucky. It's activated all your inflammatory response. Your body's figuring out how to fight something off. And some people have more of that than others, but you might get a fever, you might have body aches, you might have fatigue. It's feeling yucky. We do know that it often has some of those side effects. So a couple of days to feel better is a good idea to build in when you're setting up getting your vaccine, even though many of us didn't have any of those side effects at all. Maybe just a little tenderness at the site. With regard to longer term impact, here's what I can say. Of course, we don't know, what this vaccine does to somebody in 10 or 20 years, but it hasn't been around that long. It's only been around since last year. That said, what we do know is this. One, it's been tested on millions of people at this point. It was tested on a lot of people before that. Studies are ongoing. Now we're seeing it in many people. So we have a ton of data about what it does and doesn't do to people. Remember those reports of myocarditis? There is a small number of people that get myocarditis, which is inflammation of the heart muscle, after they get a vaccine. There absolutely is. However, what we need to do then is compare the risk of vaccine to the risk of COVID, not to the risk of nothing, because that isn't the risk. It's the risk of COVID. And COVID has a much, much higher risk of myocarditis specifically, as well as all the rest of the neurological complications and fatigue and muscle stuff and thinking stuff, foggy, all the stuff that we're still learning about that COVID does to people. All of those are the risk that you have to compare to the risk of getting the vaccine. So there is a risk of myocarditis, a small risk with the vaccine. There's a considerable risk of myocarditis with COVID, the disease, as there is with RSV and flu and a whole lot of other respiratory viruses. Those things can all cause myocarditis. What we do know about the longer term is not from 20 years of experience with this vaccine. It's from many vaccines, and what we know about that and how we can extrapolate from that to this one, even if it isn't the same thing, and specifically about that mRNA therapy. I know that at the very beginning, I was like, well, now wait a minute, what is this thing? We've never seen it before. We've never used it like this. How do we know? And boy, did that come around fast. What do you mean it came around in under 12 months? They totally didn't have enough data to be able to present this as safe. They don't know. They can't know. So I went digging through the data and took it to pieces to try to understand how they had gotten to the point where they could say, here's this vaccine. We know it's been a short period of time, but it's safe and effective. And what I found when I examined that evidence, and this is what the SHAs do, the senior health advisors, the docs that I work with at CRU, we go to the evidence and we take it apart. What kinds of individuals are represented in the data? Are the kinds of individuals that we're talking about vaccinating represented in the study participants? Are there people from all different racial and ethnic groups represented in these studies, so that we can say, here's what the study shows for the people who are in it. Does that apply to the group we care about, to the group that we're interested in at this moment, to the group that we're thinking about right now? And they did even if they didn't get it very right at the very beginning, over the course of the last year, they have included in these studies a very, very, very broad array of people from different groups who wanted to participate, who have been eager to participate and see if it works to protect them from COVID, which scared them more than the vaccine scared them, and to see about side effects and to see about long-term impacts and all the rest. So at this point, there's very good representation in the studies of people from all walks, and there's a huge amount of evidence about how it does and doesn't impact people across the globe at this point. We know about mRNA from the studies, it was researched for 10 years before they ever got it into therapies. Then it was introduced into therapies for cancer patients, and those patients have been getting therapies with mRNA for 10 years. And so we do know about what the impacts of that are in the long term. And the answer to that question is that it isn't the mRNA itself that causes side effects and things in the long term. Because like I said, that stuff washes out other parts of it, other kinds of therapies, other things can cause other side effects, but not that mRNA part.
All right, thank you. Another question that we've got is around having exposure to and having had COVID and those natural antibodies, and why are we requiring a vaccine if people have already had the virus?
That's a super good question. Well, the first thing is this. We have to know and believe that individuals who get sick with COVID have antibodies. They do. We do. Well, I haven't got it, but people who have been infected have antibodies. Some of them have very robust immunity. If you got really sick with COVID and you had a very high exposure with a lot of virus in your system, the likelihood is that you have a chance at a very robust response with a whole lot of antibodies. And the thing that we know about it is that it's super variable. Depends on a lot of things, some of which are how severe the disease was and how high the viral load was in any given case. So somebody who gets only a few viruses in their system and gets the infection and has a few little symptoms and then it goes away may not have as robust a response as somebody who has had a very severe disease. So yes, there is some kind of immunity. We don't know how much, we don't know how long. We're not sure against which variants, if there is an issue with that at all. But it's true, there is immunity and we can't characterize it very well and we don't know how long it lasts. What we do know about is the vaccine. We know how strong it is and how long it lasts, and that makes it easier to frame out an understanding of how we are and are not exposing our patients and our families and our residents and our colleagues when we go to work. So if somebody's immunity is waning, then it may be time for a third dose or a booster. We can potentially know that about a vaccine, which is consistent, and we can study it and understand what it is. When it's as variable as it is with an infection, it's hard to know what to do with that. It's hard to know whether somebody's protected, how much their protection is, and for how long, and whether they're now in a place where they're putting people at risk. So that is the reason that the decision has been made here to depend on vaccination, which we understand better. That's not a perfect answer. I wish I had one. It's a good question.
Do you want to jump in?
May I offer a little bit of a closer?
Please.
I know that many of you have made the decision already to get vaccinated and that there are others who still have questions. Please know that there are lots of valid questions about the vaccine and about all the agendas that different organizations have and all those different kinds of things. It's really hard to know what to trust, what information to pick out of all the information especially when there's so much conflicting information out there. So at the end of the day, two things. One, pick your sources really carefully. The science itself is where I can base my understanding, and when evidence is limited, it's my job to say, here is how the evidence is limited. It can apply to these situations. It cannot apply to these other situations. And that's what we are trying to do, and I invite you to do the same. Just pick your information very carefully, pick your sources with an understanding that they're of their science, and not looking at all the political agendas and is pharma trying to get me addicted to it. Like, I can't even pretend to know or understand what all those agendas are and what impact they may have, but the science I understand. And that's what we're trying to do among the SHAs over here at CREW. And the second is, when you're thinking about it, just let it be the COVID vaccine and its risks and benefits versus COVID and its risks and benefits, and not versus nothing, because this Delta is coming. It's aerosolized, it's everywhere, it's super contagious. Everybody who isn't vaccinated is going to get it if they haven't already got infected and have some kind of a robust immune response. So just hold your values very carefully there and be very thoughtful about choosing those sources. And that makes this, it helps eliminate some of the swirl and focus on the question that is most important, the questions that are most important to you and to your family, to your workplaces, and to your staff. So feel free to reach out and use us as resources to answer any additional questions you may have, again, to what's true, what's not true, and tell the truth and the limitations of it. Appreciate all you're doing on the front lines. Caring for folks is a really hard thing to do, especially during COVID. So thank you.
Thank you so much.
All right, with that, we're at 2 o'clock. We will do our absolute best to get answers to the questions we were not able to answer today. I did start this presentation and meeting with information in the chat and a link to our webpage. Please do go there. Lots of these questions are in the FAQs, and reach out if you still have questions. Thanks everyone for your time today.
Thank you.